Prozac, generic name fluoxetine. Your brain is constantly releasing and recycling serotonin, a chemical that regulates mood, sleep, and appetite. Prozac blocks the recycling step, so serotonin stays around longer and keeps doing its job. That's the whole trick. It's called an SSRI, selective serotonin reuptake inhibitor. And it became the most prescribed psychiatric drug in history for one reason. It worked, and the overdose risk was low. The antidepressants before it couldn't say that. Side effects are manageable. Nausea in week 1, possible sexual dysfunction long-term, some weight gain with extended use. But the catch nobody mentions up front is that it takes 4 to 6 weeks to work. Your doctor hands you a prescription and you won't feel anything for a month. That gap is when most people quit. But there are others in the same class as Prozac, with the same mechanism, but slightly different personalities. Sertraline, or Zoloft, is probably the most prescribed antidepressant on the planet right now. Escitalopram, or Lexapro, is cleaner, has fewer drug interactions, and is a really popular option for anxiety. Citalopram, or Celexa, is the cheaper, older cousin. Effexor, generic name, venlafaxine, is an SNRI. It blocks reuptake of both serotonin and norepinephrine. Norepinephrine handles energy, focus, and your stress response. Adding it to the mix makes these drugs hit harder for people whose depression shows up as exhaustion and brain fog more than sadness. Duloxetine, also called Cymbalta, does the same thing but also has FDA approval for chronic pain and fibromyalgia. If someone has both depression and a body that constantly hurts, Cymbalta makes sense in a way SSRIs don't. The downside with Effexor specifically, the discontinuation syndrome is brutal. Miss a few doses and you get brain zaps, a weird electrical sensation in your skull, plus dizziness, nausea, and irritability. Doctors have to taper patients off slowly because of that. Wellbutrin, generic name, bupropion, doesn't touch serotonin at all. Works on dopamine and norepinephrine instead, which makes it feel completely different from an SSRI. More activating, better focus, more energy, less of that emotionally flat feeling some people get on the other drugs. No sexual side effects. And in some people, it actually improves libido. It's also used for ADHD and sold under the name Zyban as a smoking cessation drug. Same molecule, different label. The reason it's not prescribed to everyone: it lowers the seizure threshold. People with eating disorders can't take it. Anorexia and bulimia cause electrolyte imbalances that already push the seizure threshold down. Wellbutrin pushes it further. That combination has caused seizures in patients who looked otherwise healthy on paper. People with seizure history or heavy alcohol use also can't take it. It can run anxious in some people early on. But for someone who tried an SSRI and hated the sexual side effects, Wellbutrin is usually the next conversation. Remeron, generic name, mirtazapine. It works backwards compared to most antidepressants. Instead of blocking reuptake, it blocks receptors that normally put the brakes on serotonin and norepinephrine. Net result: more of both. What makes it different is its side effect profile. It's heavily sedating, especially at lower doses. It increases appetite hard. So for someone with depression that's destroying their sleep and making them unable to eat, that sounds like a silver bullet. For someone already battling with weight, not so much. Another example of how doctors can fit each individual patient's problems to a drug's unique chemical footprint. It's also one of the faster-acting options. Some patients notice improvement in 1 to 2 weeks instead of 4 to 6. TCAs, or tricyclic antidepressants, have existed way before anything we've talked about so far, back when treating depression meant accepting a really rough deal. They work on serotonin and norepinephrine like SNRI drugs. But they also hit histamine, acetylcholine, and a handful of other receptors they have no business touching. That's where the side effects come from. Dry mouth, constipation, blurry vision, heart rhythm changes, and dangerous overdose risk. They work, sometimes better than SSRI drugs for certain patients. but the side effect burden is heavy. Today, they're mostly used for treatment-resistant depression, chronic nerve pain, and migraines. Doctors still reach for them, just very carefully. Monoamine oxidase is an enzyme that breaks down serotonin, dopamine, and norepinephrine. Monoamine oxidase inhibitors block it entirely, making all three neurotransmitters go up at once. They work exceptionally well, including for atypical depression, where someone can still feel pleasure sometimes but crashes hard at rejection and has extreme mood reactivity. SSRI drugs often underperform here. Monoamine oxidase inhibitors don't, but there's a steep price to pay. Eat aged cheese, cured meats, red wine, or fermented foods while on an MAOI and your blood pressure can spike to stroke levels. There's also a long list of drug interactions: cold medicines, certain painkillers, any of which can trigger serotonin syndrome. Because of all that, they are reserved for people who've failed multiple other treatments. Trazodone. Low doses sedate without the dependency risk of benzodiazepines. So most psychiatrists prescribe it more for insomnia than depression at this point. But it's still an antidepressant. Some studies for other drugs in the same class even show better outcomes for cognitive symptoms: brain fog, memory issues, concentration problems, compared to older SSRI drugs. But it's more expensive and not always covered by insurance. Spravato. Generic name esketamine. A nasal spray derived from ketamine. It's got a completely different mechanism from everything else on this list. It acts on NMDA glutamate receptors, not serotonin at all. It can work within hours for treatment-resistant depression. But it's a Schedule III controlled substance with serious abuse potential. So you don't get a bottle to take home. It's administered in a clinic where staff monitor you for 2 hours after each dose. It's reserved for people who've tried and failed multiple antidepressants. 8 classes. Dozens of drugs. None of them work for everyone, and finding the right one is trial and error. Switching is normal. Combining is normal. Taking 4 to 6 weeks to feel anything is normal. None of that means the drug isn't working. It means brain chemistry is complicated and psychiatry is still figuring it out. If this helped, leave a like and subscribe.